how do we do this? How do we reform the long-term care system in a way that is the most appropriate way without increasing the debt, without increasing the burden on our children?
Well, there's clearly enough money if we're looking at the health care system as a whole. And I'm talking about the acute care side of health care, not just the long-term care side.
We can't have progress and change without having some losers. And if we're going to change the healthcare system and change long-term care, there's going to have to be some losers and winners, and we're going to have massive reform.
Women who are more likely to be the survivors and the least likely to have income, less income in their older years, are going to be less likely to able to afford private health insurance.
And unless we change the healthcare providers' attitude to long-term care, I think in the long run, nothing will really happen.
Today's healthcare debate will affect Americans for generations to come. One of our primary decisions involves how we will care for our older citizens who become sick or incapacitated. Our country has not developed a comprehensive system of long-term care that is available to or affordable for most older persons and their families. As 76 million baby boomers and their parents age, this problem is being felt in more and more homes. At present, older people often find themselves impoverished by the costs of care and drained emotionally. Too often they are shuttled off to nursing homes when they should be able to remain in their own homes. Families find themselves burdened by caregiving with little or no help. And taxpayers are worried that the costs of care are exploding while public services are shrinking. To explore what must be done, the American Society on Aging brought together 9 leading experts at its 39th annual meeting, held in Chicago in the spring of 1993. It was attended by 3,500 professionals and practitioners in the field of aging. The wide-ranging debate highlighted the most pressing arguments that are converging on decision-makers and the public today. This videotape is aimed at triggering discussion around the country that can help us answer the most important questions now confronting us on long-term care. What are the key problems with our existing system of long-term care?
I have an 83-year-old mother and an 87-year-old father, both of whom nearly died in the past year, both of whom have gone through acute care, institutional care, home care, and in this instance, in institutions and agencies that I started or I'm a trustee of. And all I can say is, as now constituted, the system stinks. Largely because of a series of disjointed funding patterns, a series of conflicting at times reporting requirements without an information system, which one has to go through a whole series of hoops. As being one who helped develop the Medicare system, the Medicaid system, as well as develop these facilities, I felt firsthand, as well as from books, how difficult this current system is. So I'll just start that. We have to have something. It isn't primarily or exclusively money, but how do we develop a system that makes sense?
Quite frankly, we do have to improve the safety net. There is no question that it is a program, and I'm talking Medicaid, it is a program that is, quite frankly, not in the best traditions of American society. We have coverage issues which clearly do have to be dealt with. We have an orientation toward compartmentalization and fragmentation, and no, there isn't enough money in the system, and we do not have enough going into some of the alternative approaches to long-term care. I think we all agree with that. I think we have reimbursement systems in Medicaid where the orientation is more toward cost than it is toward quality. We've got to change that, and I think eligibility, which is basically the worst part of the Medicaid program, it demeans, it degrades, rather than enhancing and empowering, and that's got to be changed.
I wanted to comment that it seems to me that in designing our system that we need to be sure that there is the easy movement, the capacity to move from home care to daycare to other kinds of services as the family need changes and as the need of the older person changes. One of the problems is because our funding streams are so fragmented or so specific, it means that there's too many gaps It's too difficult to go from one level of care to another level of care.
Then we ought to be providing what the people want. And what people want, what they want is home care, and that's a primary thing. Now, obviously, not everybody can remain at home. They don't have the supports, or they're too impaired to remain at home. In most states today, when that occurs, the next step is a nursing home. What is missing in most states is that intermediate step, that substitute home, a non-medical home, that allows people to have as much freedom and choice and independence as possible before they have to go to a nursing facility.
When it comes to home care, we're really coming face to face with an unmet need, which is not primarily compensated at this time, and that's the reason that caregivers are so exploited as well. Well over half of those with disabilities, I was just looking at some new data, well over half of persons with disabilities living in their homes use no paid home care services at this time.
It's families and friends.
Absolutely, in what we call informal caregivers. And the reason I think truly why long-term care is a forgotten link in healthcare reform, or is in danger of being so, is because we have to convince the administration and the public that this is an unmet need which is deserving of new revenues.
Aside from the complaints about the system and the financing, I find that the largest complaint, if you talk to the patients and the provider, is the issue of the quality of care and the lack of sensitivity that many providers fail to give for patients who are in long-term care. And it's my feeling that in the long term, not we're talking about short term, that the only way to really change that is through education of our healthcare providers. I'm talking about physicians, nurses, social workers, etc. For medical schools, people may not realize only 12% of medical schools provide a curriculum in geriatrics. No wonder our physicians come out and have no sensitivity for patients with long-term care. So that I feel that unless we make a reform in healthcare education, that you can make the financial changes, but in the long run, because physicians and other healthcare providers really dominate the policies, I can tell you there'll be a big battle.
Can we fix the present system by improving private health insurance and strengthening the safety net for the poor?
And many of us in the insurance industry feel that we do need a new system, a very clear system for long-term care in the United States, but that system ought to build off the strengths of the three major participants. And those three major participants are the individual, the private sector, and the public sector. And that the system should be constituted in the form of a partnership, a three-legged stool, if you will, that draws on the very best of each of the three. I think that the first responsibility is for the individual to have accountability and responsibility for taking care of their own long-term care to the extent that they are able to do so. To the extent that they are able to do so. To the extent, and that the obligation would be that we're responsible for ourselves. There is clearly a role for the government in terms of providing a very substantial, a very good, solid safety net, and the role of the private sector in between is to provide high quality, to have full disclosure, to do things on the highest quality basis. And the three working in tandem is the way that we should solve our long-term care problem, rather than trying to say that the government can do it all. We cannot afford that.
Now, there is no question that long-term care insurance is not a panacea. There's no question that we are not going to find 70, 80, 90% of the American public capable of purchasing it. But the data that exists which actually shows who is buying it, that data shows that, in fact, much higher percentages than those who have suggested only 5 to 10% of the American public are going to purchase it. As Jim pointed out, if we go below the elderly, we find it is eminently affordable. If you purchase it at age 40, 45, 50, it is eminently affordable. I think the issue has got to be looked at in terms of affordability, not as a function of somebody's arbitrary discussion as to what price is, in fact, affordable, but the assumption is, what is the value seen by the individual purchaser of long-term care insurance? And that does not lend itself to easy, cute mathematical computations. It is certainly more affordable than those who are against it would like us to believe.
We have to come together. The old way, the way that's being proposed as through the insurance scheme, is the one that why we're looking for a reform. That is to say, we left it to the voluntary, to the individual wills of employers and so forth, and it went mad. The insurance company behaved the way they should. They cherry-picked, they segmented, they excluded, and we're in deep trouble. Let's not do that with long-term care.
I think that the insurance industry is misrepresenting the affordability issue. The issue is not whether premiums are affordable. The issue is whether the insurance policies make nursing home care affordable for those who buy the insurance. And the problem is that once you've bought the insurance, there's still substantial co-payments, deductibles, and other costs associated with the insurance. And those costs continue to go up. The nursing home policy fixes what it will pay, and the individual is left responsible for the other costs, and therefore finds that when they're most likely to need nursing home care, that care is still going to require significant contributions from that individual, and an individual who thought they had protected themselves through insurance for nursing home care will find that they didn't.
We're having a debate here about something that would take us back 20 or 30 years if we adopted it, which is a voluntary, privately insured approach that we're trying to get rid of in the rest of our healthcare system. And so if we take a more systemic approach, the way we're thinking about the rest of our healthcare system, and apply that to long-term care, then the debate isn't really between private and public, because it's going to be some of both. The issue is, what kind of system do we want to have for everyone who has that functional need? And it's not just a question of money. It's not just a question of financial protection. It's a question of, is there going to be a system there to help the caregiver, to support that family? Is there going to be a system there that responds to people's desire for independence and for maintaining high levels of functional capacity themselves, not herding everybody into institutions? And so to deal with that, we've got to get past this sterile old-time debate between public and private, and start thinking more systematically, the way we're starting to think about the needs in the rest of our healthcare system.
What are the other options, given the administration's approach to healthcare reform?
I do feel, of course, very much that it's, to me, extremely obvious that it has to be an entitlement. It's been observed that this country is literally the last, save South Africa, of the so-called Western parliamentary types to make national health care a reality, and yet we conduct ourselves as if we're the first. I think the resources we have in place and the lessons from other countries are so brilliant that we can almost instantly, with all due respect to the institutional issues, we could give every person in this country the reality and the hope of genuine health care, cradle to grave.
Basically, I think there are three problems with an entitlement program. One is, as Jim has suggested, the fact that we are talking about a massive new load of federal expenditure, which implies federal taxes. Two, I think, is the question of whether or not we really do want another program whereby those who could afford to pay for their own services are going to be subsidized by others. But I guess my problem is the third one, and that is the nursing home industry in particular has lived under something that comes close to a federally funded, federally managed program. 65% of all residents in nursing facilities are, in fact, Medicaid supported. And quite frankly, I'm very chary of a program run exclusively by the federal government, because I have found over my 25 years in Washington, the primary concern doesn't happen to be the needs of the resident, it happens to be the cost containment issues that constantly face these programs. And I worry a tad about the degree to which there is no potential flexibility in that system when the government is paying the entire check. I have yet in my 25 years in Washington, D.C., seen the government's primary concern the residents in the facilities.
I'd like to dispose of the taxes as a snare and a delusion. We're spending the money now. It's a question of whether we spend it in 4 different streams or whether we wisely put it in one and get some equity through a national tax that takes care of the health care and long-term care issue. Obviously, that needs embellishment. That's the short answer. Government medicine is a little tougher. First, I'd like to point out I'm underwhelmed by the quality of private insurance interest in quality. I haven't seen too much of that. I see a largely predatory approach to that. But that aside, we have to worry about government. Everybody has to. We have to give the government 2 tasks that it does well. At this point, what 2 things does the government do well? Well, I'll reveal them. It collects money very well, and it sends out checks very well. And we should think of that as the golden mean. That's what we should limit government to, and then do all the things Monsignor Fay is telling us to do about getting back control of our lives at the most local level. And then we'll have a decent healthcare system. We won't any other way.
But I think for all of us, we have to think very deeply and carefully about when do we use the taxing power of the state to be in support of frail people, and under what circumstances. And we have to target it very, very carefully and see what is the social goal that we want to achieve. Obviously, there are many good things about a social insurance system like Social Security, Medicare, but as good as they are, they're not well targeted, and they also bring, again, heavy burdens in the type of taxation they represent.
How can we pay for a new system of long-term care?
There's enough money in the system right now. 14% of our gross national product goes to health care and long-term care. That's 6 percentage points more than any other country in the world. We just have to redirect that money. We've gone through 15 to 20 years now of incremental changes. Most of them had 3 letters attached to them, like DRGs and PPOs and HMOs and things like that have made a little bit of progress, but they really haven't changed, because what we've been trying to do is have progress without pain.
Well, there's clearly enough money if we're looking at the health care system as a whole. And I'm talking about the acute care side of health care, not just the long-term care side. And if we can do what we're going to do, I hope, which is to do a better job of controlling costs on the acute care side, and we transfer some of those resources from the acute care side to the long-term side, then I think we can have a much better balance between the two. You can transfer it 2 ways. One way is you can create at a national level a broad enough program, such as national health insurance, that covers both acute care and long-term care under a budgeted system and allows that balancing to take place at that level. The other way you could do it is in the private sector through mechanisms like social HMOs, where you give them the full responsibility for both the acute care and long-term care, and allow them, as they are already doing in the 4 demonstration projects, to better balance across the range of need for those who are enrolled. And it works. And so I think we have good models for making that work, and it's not the case that this is too expensive to afford. We can show that, in fact, the resources are there if we do a better job of allocating.
I would agree with John that, in fact, one of the ways to begin to pump more money into long-term care is that we have to pump less money into acute care. In fact, I think one of the best statements ever made about this ongoing debate about the costs of health care in this country came from a guy called Bob Blendon, professor up at Harvard. He said the problem really is not the cost of the aspirin. The problem is how many aspirin we take. And there is going to be pain as we move into this restructured system. The pain is going to come because somebody right now is receiving those aspirin, somebody is producing those aspirin, somebody is providing those aspirin, and in the future, they're not going to get as many. And that pain is going to be interesting to observe, and that's why I'm not sure we're going to see a quick resolution to this debate, even on the acute care side in the near future.
But somebody's getting a very large profit out of that aspirin, too.
Just can't overemphasize enough that part of the debate, when one really gets in and wrestles with the issues on a very personal level, is that you look at all generations, you look at the family of man, you look at our seniors, you look at working people, you look at our children, you look at the resources we have, which are finite. We look at the fact that we're spending $300 billion more than we bring in this country every year. We have a $4 trillion debt. Much of that is going to fall on the shoulders of our children. And so you say to yourself, on the financing side, how do we do this? How do we reform the long-term care system in a way that is the most appropriate way without increasing the debt, without increasing the burden on our children, doing it in the most cost-effective way, and doing it in the most humane way?
I'd like to address the prevailing wisdom that there is an addiction among the American people for health care. People don't like health care, needles, tubes, in bed with your bottom showing. People like health. And health care, which the alleged interest in the American people in excess of health care, I would like to state categorically, is provider-driven. Doctors and other product pushers are doing it. And I can't resist once again saying that the resources are there. The enormous savings by ending the excess surgery, the unnecessary medications, the preventive measures will be measured in hundreds of millions of dollars if we get rational about our health system.
We really have to develop some social goals. And I think what we want to say is somehow we as a society, and particularly with government being an important actor in this, we have to make sure that all old people, and indeed people of any age, who are in the need of long-term care services receive them with the maximum freedom that is consonant with our ability to support it. And secondly, we want to make sure that in securing long-term care services, whether it be an infant or an old person, that this does not constitute an undue burden upon others significant in their lives, their parents, their spouses, their children. And this is the trick. How do we do this and develop a system that is, if you will, user-friendly? And something that I would just hope that as we usher in this debate, as it comes forward, that it be a civil debate and a well-informed debate, and that we understand the benefits that are needed, the systemic changes that are needed, but we also understand the burdens.
This program was made possible through a grant from the Retirement Research Foundation and the Hulda B. and Maurice L. Rothschild Foundation. For copies of this videotape, contact the American Society on Aging, 833 Market Street, Suite 511, San Francisco, California, 94103, or call 415-882-2910.